there are a whole host of reasons why lawyers unexpectedly go out of practice. It can be capacity, it can be physical issues, it can be disciplinary related matters, and the fallout is to the clients who are not there if the lawyer has made no arrangements for someone to do something when their practice starts unraveling. So that's where the discussion began. It still is primarily, in the early days, focused on capacity issues. And so the Succession and Transition Committee, which has been at this work now for 2 or 3 years, thought it was time to get back to basics. And by that I mean have somebody talk to you about what it means to be incapacitated, what incapacity looks like, how you recognize it, and some suggestions for things you can do as your brother and sister's keeper if you see a lawyer who might be in trouble with capacity questions. And to help us with that, we've asked Rex Swanda, Dr. Swanda. I will let him tell you about his credentials. He is a generous with his time, both to this committee and to the bar and to the profession. Longtime practitioner, both private practice and at the Veterans Medical Center. And if anybody knows about capacity, it's Dr. Swanda. I sit down sometimes and go through some of the things he's told me. I've stopped doing it on a daily basis to decide how incapacitated I am. With that, I'm going to turn it over to Dr. Swanda, and thank you for helping us today.
Well, absolutely. It's always a pleasure, and I'm always honored to be asked to help out. And I see Gail McConnell there, Briggs Cheney, and I've been working with Mr. Sleaze over a few years, and this is really interesting. The whole area of succession planning, I can tell you, as a psychologist, this really overlaps with things that are going on in my profession as well. And I think we all recognize psychologists and attorneys have a lot of similarities in setting up professional practices, a mix of working for, in large groups or solo folks. I'm kind of curious, out of the people that are here today, how many people are solo practitioners, more or less? So at least half. So I get it, and I'm right there with you, sort of. It's kind of like any other kind of estate planning. And so as we go through this morning, I'm going to try to keep my remarks on the informal side, and I can tell you right now, I'm really going to welcome any questions that you have. I think the questions will help all of us focus and get to issues that are more relevant for you, because I don't think I'll be saying anything that's startlingly new for anyone. In fact, I think the context, and Bill has already set this in motion in the work of the committee and the whole focus on succession planning, to think about this as a process, right? So this isn't something that, okay, over the weekend or maybe a month from now, you're going to sit down and do it. Just like, I might set up an appointment with an estate planning attorney, but that's like dipping my toe into the water because it's not all done on the day that you meet with that attorney. And the day that you decide to do succession planning, whether you start on that today, it's not, it'll change and it'll evolve. Okay, so what I'd like to get to is to say a few general remarks about the things that Bill was already introducing. Dementia is, I think, a general concept. And this dementia is a broad umbrella term that refers to a whole lot of different conditions that are all characterized by deterioration. I want to just check this out and see if the pointer function works. Oh, yeah, it does. So all of the conditions that are comprised by the general term dementia are characterized by some kind of general decline in cognitive functioning. So specifically, if someone was always pretty low functioning over the years, and they stay low functioning, that's not necessarily dementia because it's not marked by a change in functioning. So we're in that broad territory. But other than that, here are a bunch of different examples of conditions that might fall under the umbrella term of dementia. Of course, most of us think about Alzheimer's, which is probably the most common, and And most of us have been touched by folks with dementia of some sort, especially Alzheimer's. So Alzheimer's, just to say a couple words about that, when I'm seeing a patient and offering a diagnosis of dementia due to Alzheimer's type dementia, what I'm really focused on are two main hallmarks. And the hallmarks are really severe memory issues. The kind of memory where the person, at least up to moderate stages, is able to retain their past memories and a sense of who they are. Generally, I'm talking about folks who still can recognize family members that they've been close to over the years. But maybe if they see a friend that they knew, they see maybe twice a decade, they'll have trouble placing them. But then, after a little bit of conversation, you might be able to spark the old memory. But the difficulty they have is they can't lay down new memory effectively. So the kind of testing that I do as a neuropsychologist is to see how well the person can do things like learn a list of words. And maybe we typically would repeat that list of words, maybe throw 12 or 16 words at them and just see how many words they can cumulatively learn over 3, 4, 5 presentations. And then go on to some other things and come back about 20 minutes, half an hour later, at any point when that information can't just be circulating in their attention, and so that we know they're not just rehearsing the information. And then ask, can you tell me as many words from that list now? And what we're doing there is we're inviting them to do a search of stored memory at that point. And that becomes actually the gold standard for, in many ways, diagnosing something like Alzheimer's. There are other dementias, and you'll see on the list things like the maybe vascular dementia, which is characterized by problems associated with either stroke or sometimes you've probably heard of mini strokes, or the technical term multi-infarct dementia, a process where the blood vessels are getting clogged over time. And of course, what clogs up first are the very tiny little capillaries, and sometimes when they clog up, they can result in almost microscopic strokes. And on an MRI, you can visualize those and see little dings scattered throughout the brain. Typically, no single infarct of that sort is necessarily even going to be noticed. A family member might observe the person on a particular day, just seem a little sluggish. These are the kind of things that are associated with all kinds of vascular problems that also lead to heart disease or other plugging up of the vessels. So the real key to that is guarding our vascular health. That's why our doctors, keep on us to keep our blood pressure managed. Diabetes, that's a real silent, and destructive villain in this picture because it contributes to breakdown of the arteries and blood vessels. But in the brain, it can cause a whole mix of presentations. That person may not show obvious memory problems, but probably would show some of what we call executive difficulties. And the executive problems, I think people hear about that more. How many folks here in the room kind of are vaguely familiar with, I'm not going to pin anyone down, you can raise your hand, I won't be calling on you. But how many folks know that term executive? I'm just trying to gauge how much detail to go into. It's an important notion, thanks. And again, I think more people in the room than not. Executive functioning has to do with those higher, very human abilities. I'm a dog lover, so I think dogs, you can see executive functioning in dogs when the dog figures out what's the quickest route to chase that rabbit. Those are executive abilities. Those split-second decisions of how to plan ahead and anticipate how to reach a goal. And so you can imagine if those kinds of abilities to planfully organize, to initiate. Initiation, doing things on our own, that's what every parent wants your kids to, the kid to do. Clean the room, study. And that's drilled into us. But even as adults, a lot of us, struggle with initiating things. But when the person truly cannot initiate, can't plan, organize, and just as importantly, that ability to monitor ourselves. Self-monitoring is really key because it's that self-monitoring that allows us to catch mistakes and fix them, hopefully before anyone else catches them. So those are the kind of things that can break down not only in vascular dementia, but probably all of these. I'm not going to go into as much detail on all of the others, but I do want to touch on the alcohol-related dementia, which often is characterized by both the executive problems and often memory problems. So in very late stages, persons with a very long chronic history of very heavy alcohol use have basically burned out some of the organ structures that are essentially for laying down new memories. And again, the person might retain a lot of even some well-practiced wit, and they've got a host of stories that they've been telling over the years, and the personality that, so that their behavior looks similar. They're maybe entertaining, maybe the person's always been the life of the party and they still are. And for me to meet that person in a hospital when they come in after a long binge, they may be very deft and quick at kind of changing the conversation and controlling and guiding where they want to go. But on further exam, on formal exams, they have a lot of difficulty learning a word list. And sometimes these are the folks who might also start filling in gaps. The social skills work overtime, and they know that you're expecting them to talk about something. And so I might ask, well, can you tell me the name of the President of the United States? This might be someone who really hasn't been laying down new memories for a lot of years. So it's not uncommon for a pretty bright appearing person to maybe tell me, oh, well, yeah, it's Bill Clinton, or that it's George Bush. And they've got a double chance of being wrong. But and they'll say that, so we call that confabulation. My point here, in going into some detail, is that all of these conditions have their own hallmarks, but the one thing that characterizes all of them is loss of insight. And loss of insight, I'll have a slide in a moment, in fact, I'll go right to it, is really the one characteristic that is the big problem that makes succession planning critical. Loss of insight is about the main thing that drives a guardianship matter. It's not that the person is impaired. It's not that any more than the fact that someone might have difficulty with their gait, trouble getting around, slowing down, relying on glasses for vision problems. That doesn't make me impaired enough that I would have to give up my practice necessarily. If I have insight about the fact that I have really bad vision, I can compensate for it. If I have insight that my walking ability is no longer what it used to be, I can't walk so steadily. If I don't have insight, then I might be out there walking on uneven surfaces, and guess who's going to fall? And then break a hip and have all the accumulation of other problems. It's the insight, though, recognizing, oh man, maybe I'd better be on a walker. I hate to admit it. Or maybe I'd better use those glasses because I can't drive. I just can't see without them. So as long as any of us has insight, we can pretty much compensate. I do a lot of work with a number of attorneys, at least, I see at least one that I've seen in the guardianship circles. And when guardianship issues come up, my examination, of course, I look at the person's level of cognitive functioning, and I might see impairment. Sometimes I don't see much impairment. But what I'm really focused on in my interview is to try to assess the person's level of insight. And that's what I'm asking all of you to think about here today. And in fact, I don't really have to make much of a pitch for this because I know that every one of you who's here today in the room recognizes this possibility. It's like an admission of our own, mortality, and it's just another risk management strategy. So I don't think I need to do too much cheerleading for folks that are here, but maybe everyone who's here can help spread the word to our colleagues. If you're in a practice with someone who isn't here, and you're in that office, and you might bear some, whether you want it or not, there may be a little bit of shared liability. That's what attorneys always tell psychologists. we're exposed all over the place. So I would, maybe the real task is for folks here to also spread the word, and just like I want to do that with my psychology colleagues, to plan ahead. We had a terrible tragedy in our city a few years ago, and a psychologist who was known by many was murdered. No one anticipates that. Any more than any of us anticipate losing our faculties, losing the thing that attorneys, psychologists, professional people value the most, our ability to think. We don't anticipate that. We don't anticipate possibly being in a motor vehicle accident and sustaining the kind of traumatic brain injury that also, sadly, can frequently result in impaired executive abilities and loss of insight. And so, of course, that's what the succession planning is about. I want to pause and just remind folks, if you have any questions or I'm not on a track that's interesting to you, raise your hand and ask a question, and I will rapidly, and flexibly try to use executive abilities to respond and make a shift. Hi, Jill, yeah.
One of the things that I see a lot of times is aphasia, and I'm wondering kind of where that fits in with the different types of dementia, if that's real common with all of them or certain
Perfect.
ones.
Yeah, that's a great question. Just coming back to this slide, the question involving a specific symptom like aphasia, which has to do with problems with language. It could have to do with expressive language, getting words out, or it could have to do with receptive language and comprehension, understanding. And that's very interesting when someone has specific problems with the understanding. They may be able to speak fluently, but think about the concept of insight and the combination of not having insight, not having an awareness that there's a problem, and not comprehending. And so in those sad, tough cases, we sometimes see someone who speaks with what we call a jargon aphasia, where they may be uttering sounds, and in their mind they know what they're saying, but because they don't have feedback, they can't understand the very words and the sounds that they're making. They can't self-monitor. Remember I was talking about self-monitoring and how important that is as part of executive functioning. It's like they've lost the feedback loop. And so what the listener hears is someone speaking just gobbledygook. And the tone, the intonation, the melody might sound like real language, but the words are meaningless. at any rate, I'm off on that tangent, but when we get into those very specific syndromes, that's probably most likely to be call attention to some kind of focal problem that's happened in the brain, meaning in a very specific area. And that is probably going to cue us that we're in the territory of either a stroke or a vascular type problem, or it could be someone with a tumor that's arisen. Again, affecting a very, very specific part of the brain. That person may actually be doing pretty well in other areas, and they may actually retain insight. I can tell you that one of the most painful things for the person with aphasia who has trouble getting words out is that they're painfully aware that they can't make themselves understood. And it could affect both oral, spoken language, as well as written. And that can be really tough. And the pain of it is having the insight and awareness and the frustration that goes with that. So aphasia would be one example of a specific symptom that may or may not be associated with a general decline in dementia. Almost on a par with, wow, I've had a stroke, or I had a very focal brain injury due to trauma that resulted in paralysis or weakness in an arm or leg. It's almost at that same level. Doesn't mean that the person's demented. So there are a lot of symptoms then, and we're in that territory. Do you know, Jill or Bill, do the folks have notes from this? I can make them available if you're interested, but
I don't know that they do, but we can make them available.
I wasn't, I'll go into a little more detail just for a moment, because there are a lot of specific symptoms, again, along the lines of talking about language breakdown, but in general, I would kind of characterize the kind of problems that you see with dementia as changes having to do with the person's confidence, their competence, their ability to do things, and their character. I kind of, because there's a little bit of alliteration, it sounds good. But on the confidence side, I put that in to cue myself to remind all of us to think about what's going on with the person, whether we want to think about it being ourselves. Personally, I'd rather consider it being a colleague. But imagine someone who is experiencing cognitive impairment and that decline. And I'm not even going to ask people to raise their hand, because I'm going to assume that everyone in the room has been touched by someone with some version of dementia. And we know that that's tough. What we experience when we see someone, especially a loved one who's declining, is what a burden it becomes. And if you think about as a caregiver and scrambling to try to keep that person secure and trying to find that sweet spot of helping them be safe without smothering them, and sometimes avoiding the wrath of someone who's really irritated and thinks that you're just doing too much for them. So if you can kind of imagine what it would be like to start slipping, and if you're already aware and thinking that you're having some kind of subtle problems and wondering if, wow, are these early signs? I do want to tell you, and I'm not joking, I think you're probably in a stronger position than the person who hasn't considered the possibility that the little everyday problems that come up could be dementia. So the more aware you are, the more you're monitoring, and frankly, the more you worry about yourself, the less I'm going to be worried about you from a diagnostic standpoint. And I have a lot of experience. For years, I worked at the VA. I've worked at a couple of other hospitals. And the most frequent, and frankly, just my everyday cases involve people coming in who were worried about their own symptoms. When I saw that was the referral, a few weeks before they'd seen their primary care doc and said, I got to tell you, I've been having some memory problems. I walk into another room and I forget what was there or what I went in there for. I was even driving home the other day. I'd gone to the post office and I found myself going down a street and I didn't know where I was. And it took me a minute to kind of get back. Well, if those examples are worrying you because they've happened to you, they've happened to me. They've happened probably to all of us at one time or another. And the fact that the person is aware shows some insight. The fact that they're kind of worried about it shows additional insight. And the fact that they're telling their doctor about it, and then a few weeks later they're telling me the same thing, and they're even more worried because now they're in that kind of doctor's office. That tells me not only do they have insight, but they've also got good memory because they're telling me in extraordinary detail this account of things that happened weeks before. And so I'm already pretty reassured. And maybe I'm expecting to see them having some difficulty with attention and concentration, the sort that happens for any of us when we're a little distracted because we literally have a lot on our mind. But when I come back and ask them to remember those words half an hour later, they can muster a pretty good retention of those words. When I get more worried is when the adult daughter or son or the spouse brings the person in and they think they're just fine, and I can see the pleading look in the background. Please, can I have a minute alone with you, doctor? And because there's also a lot of reactive emotion going on. And that's kind of what I'm getting at with the character side, because, but also with the confidence. Because for that person, I think at some level, there's usually a glimmer of recognition early on that all is not well. But lacking the insight and that ability to truly self-monitor and remember, to have the cumulative memory and record of all the little things that are happening, leaves the person feeling really uncomfortable, and it's scary. And so I think when I kind of switched around in my own mind and took my focus away from focusing on me and, would I be able to see the problems, would I be able to diagnose? When I kind of turned that off, which is really like turning off, making it about me, the provider, and started making it more about the person and trying to understand what's this person going on, what's going on with this person. I think that was a point in my professional life when I really started to be able to do some better work and have a real conversation with someone who's impaired and lacked insight. And because a lot of that conversation had to move away from a defensive butting heads. Oh, I know better than you. I'm telling you what's wrong with you. And when we shift into, let's have a conversation. What's going on with you? Not only am I assessing how much insight the person might have, but I'm also seeing the emotion, and that kind of helps us as humans figure out how to get around some of that head-butting and the defensiveness and the lashing out in fear, because it really is fear. So I like coming back over and over to the, reminding myself about a lot of what we're seeing and might be experiencing ourselves is that change in confidence. It's not just about competence and ability. And then, and the changes in character. That what we're dealing with is someone who families might describe as, wow, Dad used to just be so generous and sweet and always there to help, and now he's all closed in, just kind of hangs out and just watches TV and avoids us. Those are all clues. Please.
I dealt with this with my stepfather, who was a lawyer in another state, and I was thinking, I never saw a lack of confidence. But I'm wondering if what you see is more defensiveness, like absolute determination to cover that you're not as confident. So you're getting more blustery and stubborn, or seemingly stubborn.
I really thank you for making that excellent and really important point. You're right on. The point being, if anyone didn't hear that, an example of someone who not only appears to retain confidence, but in fact is even more maybe overconfident and more blustery. And again, I think that calls attention to the fact that you're still talking about a change in a sense, but in that case, there's sort of like a hollowness to a hollow confidence.
You might not hear, wow, I really don't know what I'm doing anymore. I mean, you might not hear it that way if
That's
it's
right.
covered up.
Right, because if you heard that, that would actually be both insightful and frankly appropriate maybe. And so, but instead what you see is maybe what we could label defensive, which you mentioned. Yeah. And so I like focusing on kind of the generalizations, and then everything else follows from that. So we can go through a lot of examples of ways this would show up, but instead of me listing those, are there other examples that folks have seen, or that you might imagine might be examples of how that might show up? Early signs of dementia. Yes, in the back.
You used the word slipping a little while ago, and I think that kind of is my concern. I don't think I have memory loss. My problem is being able to access the memory. Sometimes in my area of the law, there are certain leading cases that I've been using for years. The other day, I couldn't remember the name of one of the cases. It took me 20 minutes to remember the name of the case. I mean, it finally came, but it took a while for it to come. And it's starting to affect my confidence. So how do we deal with this?
Good. So, and again, that's why I appreciate the examples that are real life, because that's a really good example, in my opinion, of, and maybe goes back to what I was talking about earlier, that in fact, all of us, and I'm in the midst of this, I'm part of it. And if we're, I guess, fortunate enough to continue aging, it's not usually a good thing when you stop aging. So assuming we're kind of moving along in age, the fact is, in my line of work, all kinds of research tells us that basically from the 50s on, we can all expect to start having increasing problems with what we call word finding difficulty. It's so common that we just refer to, word finding difficulty. We pass it off like that's nothing, but it can really get in the way at times. And I think the example that you mentioned, like trying to think of a very specific piece of information that you know, it's common, it's in there, and you just can't quite access it, is a variation on that word finding difficulty. It's not that much different than a word being on the tip of your tongue, but you just can't grasp it. And just like a word being on the tip of your tongue, sure enough, about 20 minutes, or when you no longer need it, there it is, it floats up and it's right there, right? So, but if I can use your example, and I appreciate that, a couple of other things that I think are points that you've made is to remind us that in that example, it's vexing, and so the frustration and the kind of mild concern that you feel is, again, a good example of insight and appropriate worry. But it's that kind of little low-level anxiety and in the back of your mind that might also propel you to compensate for it, to take steps to, okay, maybe I just need, wow, if I'm going to continue practicing, maybe I just need to organize things. And, well, I'm pretty good with the computer, so I'll just create a file and just make sure I have the things physically filed. And in going through that process, it kind of exercises that review of those pertinent cases, et cetera. And we all have our own way of doing that. Yes.
There's a term you use, and I don't recall it immediately. I talked to you about it 2 or 3 weeks ago when I woke up, when I was traveling in a hotel and wasn't sure what city I was in, and started deciding I was definitely around the bend. But particularly as we age, talk a little bit, if you can, about the fact that especially attorneys who are expected to keep 30 balls in the air at once, and when I was in my 30s, I could do it without ever putting anything on paper. Some sort of attention deficit almost. How does that interplay with all of this?
Again, just I think, again, those are examples that we really expect to see with normal aging. And one of the reasons, other than being a neuropsychologist and kind of pushing my own profession, but I think the valuable thing that neuropsychology brings to the table is that it's based on a very well thought out set of observations that kind of marry the kind of normative-based testing with the theory as well as the results that we see in real-life neurology and neurosurgery. So what I'm really talking about is if we test a person in our lab, and in fact, if a research neuropsychologist wants to look at a test of word-finding difficulty coming up with words, or how many things can you juggle in your head, which is basically attention span. How do we do that? Well, what we would do in neuropsychology is look at numbers and plot things out statistically and find out at what point is it normal to deviate from the standard. So we might test 1,000 people, preferably not just college sophomores, or just male veterans in the VA. But thank you to the US government and Veterans Administration for actually pretty much funding most of the research of neuropsychology beginning after World War II, when we actually had so many veterans being cared for in this country. And that really sparked the kind of science and practice we have. So what we do is we look at large numbers of people, measure them, find out what's the standard deviation, or what's the normal range that you can vary within one standard deviation around the mean or the average. And then just statistically define if a person's performance goes more than one standard deviation beyond, either lower or higher, that puts them into the, extra quick and bright side, or the low average, the moderately impaired, severely impaired range. So that brings me back then to your question, when we would look at the difference between an attorney in their 30s, juggling a lot of things in their head, we could look at attention span and then compare, what's the attention span then for an attorney in his or her 50s or 70s? And then if I'm being asked as a neuropsychologist to weigh in on something, kind of the equivalent of fitness for duty, can this person still do their job? And I sometimes have the interesting opportunity to see a physician or a neurosurgeon I saw once in their 70s. And the issue is, can they still practice? Well, I'm not going to just hold a neurosurgeon to the standard of, this person's doing fine compared to other people in their early 70s. I want the neurosurgeon working on my brain to be the equivalent of someone in their 40s at least. That's just me. But I got to have an opinion in that case. So does that kind of get at a little bit of what you were talking about?
And presumably that's more along the normal scale.
Yes, yes. So and that's really the main point, that as we move along, what we were doing in our 30s, just like, not that I was the fastest runner, but I used to run faster than I would now. I'm not even going to bother now.
So is there a point at which we cross that we should be very concerned, not just about ourselves, but others?
Well,
And we see in our colleagues that we should have flags, and then if so, what do we do about it?
So I think that really brings us to yes, and the difficulty of that is we can observe all kinds of problems, a couple examples of which we've been talking about here now. Things having to do with memory, the so-called slippage, not being quite as on top of multitasking. Sometimes people come in and say, I'm just not multitasking. And I think most neuropsychologists would respond, that was never a good idea. Yeah, because I don't know where the premium got, where somehow it was placed, like it was a good thing to be multitasking, because what you're really doing is doing one thing while you're distracted by other things. So but the real issue is that the person's talking about changes in their functioning. And so some of the other things that we might see in colleagues might include things like showing up, just getting the paperwork for a brief, presenting a brief in court and arriving only to see that they're even the kind of punctuation errors, the things that make a professional's work look sloppy. So I've been, up to this point, really also trying to talk about how normal a lot of these changes are. But at the same time, when we're concerned about a colleague, I also want to warn against that very human and normal tendency to normalize behavior, to look at like, oh, that's just Dad. He's always been that way. Or, oh, that's, yeah, Mary, I'm actually kind of appreciating that Mary's not quite such a stickler for details. It's so much easier to be around her now. When what we're really seeing is someone who's just not on top of it. And maybe in some ways that might look better, but we normalize and we don't go right to the point of thinking, wow, this person, I wonder if this could be the beginnings of some kind of dementia. No one really goes there immediately. In fact, by the time people show up in my office, they've usually been through 2-3 years of family picking up on little things. When I go back and ask a spouse or an adult child, so how long have you been concerned? Well, I didn't really get concerned until about 6 months ago, but now that I think back on it, it was like 3 years ago when Dad shifted all this money and then lost it, and that never would have happened. Or when literally a guy who would hoard cash on the property got up in the middle of the night 3 years before, somehow disturbed, and apparently took about $5,000 and hid it, never to be found again. And that was, but the family didn't really pick up on that. They just thought, oh man, maybe that was like sleepwalking or something. But that's like the normalizing, and that's something that we really have to battle, because you don't want to, no one's going to want to precipitously call alarms to concerns about a colleague. Those are professional relationships. And the other fact is that incremental changes are really subtle. We don't see, if you have a colleague and you share an office, or someone that you know their practice pretty well, you see them pretty frequently, day to day, you're not going to see those dramatic changes. You may tend to start, accumulating, wow, that's like the 4th time this year that my colleague came in and with a new scratch on the car. That didn't used to happen. And the other thing is that the magic of autopilot. We all think about your day and think about how we all function. Most of us function on habit and routine. Even for complex activities like the practice of law, I'd say in my own profession, I've been doing this like 35 years if I count my training years. I've been doing testing. I mean, I've memorized those manuals when I was in my 20s. I'm in my 60s. I could probably appear to do an exam, but when people come to me, they don't want me to just talk through the questions. I might be able to score it up pretty well, but what they really want is the interpretation, the putting together and integration of information, which is what folks want from an attorney. They want you to, they bring the problem, and so a lot of the superficial things, though, that an observer might see would be someone coming in at the same time. They've been getting up, going through the morning routine, getting showered, dressed, hopefully appropriately, and showing up. And that might get a person by until they're maybe in moderate stages before a judge finally says, oh, wait, what, can you let's take a step back. I'd like to meet in my chambers. That's not usually, that wouldn't be a good thing. So having structure, though, and the force of habit can really mask a lot of these problems. So the real key, of course, is what we're all here for today, is to focus on, when problems arise, we can't predict when they're going to arise. And because of that, we want to have a plan in place before any problems come up. And so I think it's probably a good thing to assume that we'll lack insight when we need it most. I think my favorite point when I think about things like estate planning, succession planning in this case, is, and I bet I'm not the only one who values the notion of control and self-destiny, self-determination. And this is about the best we can do. And even this is not a guarantee. But I know in the world of guardianship, a lot of times, if someone has well-written plans in place, there are exceptions, but usually it's not a waste to have put down in writing and documented what you would like to do and how you would like things to go, who you would trust. And so this is a question I have for the folks in the room here. Who would you trust to do what? And I'm not an attorney, so what are some of the things that you need to get looked after if you weren't able to do that yourself? Is there anything in your practice that you would kind of like to have a say in? Sure.
What happens when you look around and you realize the people you would trust to manage your practice are all as older than you are?
Yeah, I get that. Yeah. What happens? So this is, I know what I would say for myself, and this is where I think it gets very individual, and I'm pretty sure this is why everyone's, the folks that are here today, and especially the folks who aren't here today, why it's important to sit down for that very reason. So you're really saying the people who might be your obvious first choice to trust, who would know your practice, who would kind of have an idea of how you've been handling your clients over the years, and the kind of clients that they might expect to have to deal with, the record keeping, just all those responsibilities. Who would you trust to do those things? So any thoughts?
Make younger friends?
Yeah, mentor a younger colleague, which is a nice service for any profession.
And I definitely want to get to that, especially because that's what we're going to do most of the second hour. But I do want to ask you a quick question before we leave that.
Sure.
Which is, partly it's trying to recognize in yourself if you have an issue, but we all will interact with colleagues, and we will come across one who we have some concerns about. And in the substance abuse world, I think we're all familiar with the idea of an intervention. But this is a little bit different. I mean, what do you do when you have a colleague who you are convinced, it might be your law partner or it might be somebody you office share with, what do you do at that point? Do you have recommendations for, do you confront them? Do you call a lawyer's assistance? Do you call the disciplinary board? What do you do?
All of those are, I think, good possibilities. But as I note here, really it depends on what's going on there. I think some of the things that it would depend on would be, first, to recognize what's your relationship with that person. That's going to be a big depends kind of question. If it's someone that you know well, if you have a history of maybe having actually had conflict and worked your way through it, you kind of know how that went. And that would become a model for how this might go. But keep in mind, the person you're concerned about, the reason you might be concerned is because there may be a fundamental loss of insight, a defensiveness, a strong, so what I would be thinking about would be, is this the sort of person who's going to get really defensive and maybe even kind of explosive and, I don't want to deal with you anymore, a little paranoid, which might mean that you have less opportunity to intervene and try to be helpful. So that's the first thing, and that's totally individual. So, but I would say to do that kind of assessment, this is, you don't need a professional psychologist for that. This is what we do as humans. We just, kind of judge our relationships, and that's how we run our lives. So I think maintaining realistic expectations. If you're someone like Briggs Cheney, who has a long, a lot of practice, frankly, and brings, both compassion and understanding to a situation, but really has the benefit of having, okay, I've been in a lot of these situations. This one kind of reminds me of the time when, then that's a distinct advantage. So one option would be to consult. Maybe consult, seek out, and that's what we're talking about and why it's so neat with the opportunity to have the assistance available and the resources from the bar. But having realistic expectations that, okay, I may not be, based on my relationship and what I'm seeing here, maybe I'm not the one to carry this forward, but I might need to hand this, off at the right time and make a successful pass. I actually think one best way, default way to proceed in most of these situations that involve a difficult conversation is to just have the intention of planting a seed. You drop a question, hey, how you doing? I did want to point out, I felt so bad for you. I know how much you love that car, and I saw that ding, but the other thing that I was worried about on your behalf, wow, what did that feel like when you kind of got upbraided by the judge? You doing okay with that? If the response is, I don't know what you're talking about, maybe you're in the territory of this person's not even getting the memory. And that tells you something. But if they get it, it's like, well, it's okay. And I say, well, I just want you to know I'm here for you. Maybe that's what you do as a first step. And then you follow up and at each encounter, what's that feel like? But I think almost certainly you're going to be sooner or later in that territory of seeking other resources. So I think in the vein of maybe as a default, planting a seed and just offering some gentle feedback. I am kind of concerned. Do you have a good doc you're working with? Do you have a primary care provider that knows you? And I just encourage them to get checked out. If you know the person's family, and a lot of us know our, a close colleague, we know spouses and children. If it feels like you can do that in a way that doesn't violate friendship or confidentiality, You might need to have a discussion with family members. For a colleague, you probably wouldn't be in the position of recommending a specialty exam, but a neuropsych consultation might be recommended after a physician visit. I also wanted to mention there are some other professional resources. I was having a quick discussion with Jill before this, but a couple weeks ago I was over here for a guardianship association meeting, and Gail McConnell had brought one of our graduate students from the psychology department here at UNM to talk about motivational interviewing, and I really appreciated that. And I was kind of, wow, I've kind of been involved. Why didn't I think of that? And I just thought that was so neat. Motivational interviewing started here at UNM by Bill Miller. It's really internationally known, and it's very widely practiced and trained because it's a great way of kind of working around difficult conversations so that when you find yourself butting heads, you kind of sidestep that. It's a little manipulative, but that's what psychologists and some attorneys are known to do. We help people reach their goals, and if it involves having a conversation that strengthens a person's resolve. Now, the motivational interviewing may not be something that you're going to master and put into practice, but I'm bringing that up as from the perspective that there are those tools out there that can be helpful. The person who totally lacks insight may not be able to be directly helped, but maybe the family. That might be a tool to use with a family who's having trouble coming to grips. I think I'm kind of at the end of what I'd prepared, and I see by the clock we're past the time that was prepared. But I'm not in any rush. It's more on your schedule.
Sure.
So.
Thank you, Dr. Swanda.
Well, thank you.